Pneumocystis pneumonia. The agent causing pneumocystis pneumonia, PCP, has been renamed P. jirovecii instead of P. carini. PCP occurs almost exclusively in patients with AIDS whose CD4 cell count has dropped below 200 per microliter and who are not on prophylactic therapy. Patient with AIDS presenting with dyspnea on exertion, dry cough, and fever. The question will often suggest or directly state that the CD4 count is low, below 200 per microliter, and that the patient is not on prophylaxis. Diagnostic tests. The best initial test can be either a chest X-ray showing bilateral interstitial infiltrates or an arterial blood gas looking for hypoxia or an increased AA gradient. LDH levels are always elevated. The most accurate test is a bronchoalveolar lavage. Sputum stain for pneumocystis is quite specific if it is positive. If the stain is stated to be positive, there is no need to do further testing. A negative sputum stain means you should answer bronchoscopy as the best diagnostic test. Tip: a normal LDH means you should not answer PCP as the most likely diagnosis. You cannot distinguish PCP from mycoplasma, chlamydophila, or viruses by X-ray alone. However, in HIV, PCP is most likely with interstitial infiltrates. Treatment: trimethoprim/sulfamethoxazole, TMP/SMX, is unquestionably the best initial therapy both for treatment and for prophylaxis. Add steroids to decrease mortality if the PCP is severe. Severe PCP is defined as a PO2 below 70 or an AA gradient above 35. Atovaquone can also be used as an alternative to TMP/SMX if the PCP is mild, meaning there is only mild hypoxia. If there is toxicity from TMP/SMX, switch treatment to either clindamycin and primaquine or pentamidine. Note: rash is the most common adverse effect of TMP/SMX and bone marrow suppression is the second most common adverse effect. Although clindamycin and primaquine may have more efficacy than pentamidine, the patient seems to have glucose 6-phosphate dehydrogenase (G6PD) deficiency and primaquine is contraindicated in G6PD deficiency. In addition, antiretrovirals are relatively contraindicated in acute opportunistic infections because of the possibility of immune reconstitution syndrome. PCP prophylaxis. Start treatment to prevent PCP in those with AIDS whose CD4 count is below 200 per microliter. TMP/SMX if there is a rash or neutropenia from TMP/SMX, use atovaquone or dapsone. Aerosol pentamidine is not used as second-line therapy for prophylaxis because it has less efficacy than either atovaquone or dapsone. Dapsone is contraindicated in those with glucose 6-phosphate dehydrogenase deficiency. If the CD4 count is maintained above 200 per microliter for several months, prophylactic TMP/SMX can be stopped. Azithromycin is used as prophylaxis for atypical mycobacteria and is used when the CD4 count drops below 50 per microliter. These cells are fully functional and they will prevent opportunistic infections. The use of prophylactic medications is based on the CD4 count, not the viral load.